Hi, welcome to Mad Medicine with Miss P. And today we're going to talk about different findings, the things that you may not normally see in your patient. So, Foley's, chest tubes, PICC lines. We talked about IVs last week, so that should be fairly covered. But things that are a little bit different and you're not used to seeing, maybe rectal tubes, ostomies, that sort of thing. It's really not that tricky. Basically, I always try to say, like, I want to teach you how to fish. I'm not just going to give you the fish. I want to teach you how to fish. So it's very simple when you find these things to assess them. We'll talk about the note and how to care for them later, but right now, just how to assess them. So if you stay head to toe, for the most part, you want to stay head to toe, and any abnormal finding, or abnormal meaning different than your average patient, like if you find a shunt. So if you find any sort of let's say, cranial abdominal shunt, you may find that you can kind of feel the rope-like structure that kind of, runs down here and then disappears, and, maybe under the clavicle or that sort of thing. You literally chart it just as you see it. Describe it the best you can. If you want to measure it, quarter centimeter rope-like palpable structure or mass leading from, this region, whichever, wherever it is, if it's occipital or temporal or that sort of thing, and, running down to posterior neck, resolving or, stopping at the clavicle, and that it goes internally down to the abdominal cavity, and that's to get rid of or help shunt or move excessive fluid from hydrocephalus, that sort of thing. Hopefully, a non-acute problem. Generally, you are going to find that, in a long-term care facility or wherever you work. That's usually something that stays in for a long time, if not indefinitely, kind of a forever issue. Normopressure hydrocephalus, let's say. We had a patient not too long ago with that, and that's exactly what she had. It was like a kind of occipital temporal shunt, and you can feel and see the rope-like structure, and it kind of went down her posterior neck and kind of disappeared behind her clavicle there, and then it goes internally all the way down to her abdominal cavity, where that fluid collects and is kind of sifted from your body or filtered, distributed the way it needs to be from your abdominal cavity. And that's kind of, what your body does when it has fluid that needs to go someplace else. So, and that's literally just how you would chart it. And exactly what you see. It's not that tricky. Same thing with a defibrillator or pacemaker. All you can say is that there's a firm, palpable mass to the left upper chest, measuring approximately 3 centimeters by 4 centimeters, 4 by 4, 3 by 3, whatever you get, measure it. I always kind of keep my little McGann pull out measuring device with me at all times, because you never know what you're going to find, whether it's a wound that you have to measure to make sure it's getting better, or whether there's some sort of abnormality you need to assess and be specific on how you describe it, like an ostomy. And these things really aren't that tricky. If you find this patient has what you feel is a hernia, well, you're not a doctor and you can't decide that it's a hernia. You can say that, walks like a duck, quacks like a duck, smells like a duck. Chances are it's a duck. What's a duck smell like? I don't know. But you would describe that in a way that you could get your point across without saying, I think it's a hernia, because you're a nurse and we can't diagnose hernias. But you could say, like, let's say ventral. I see them all the time, every day. Good God. I'll say softball size, or if I need to measure it, I can measure it. Soft, palpable mass, reducible, palpable mass. That means you can push it back in. Tumors and growths and that sort of thing, they don't usually are, they're not movable, or you can't reduce them. So if you can reduce this, which means push it back in and kind of put it back where it's supposed to be, that kind of lets the reader know that chances are there's a weakening or tear in the muscle wall where something from the inside came out. Whether it's umbilical, femoral, inguinal, ventral, incisional, wherever it is, you just describe it exactly how you see it. And when you use the term reducible, it kind of lets the reader know that if you can put it back where it goes, it indicates that there's a good chance that it's a hernia. Still, if there's nothing in the chart, you didn't get it on report, you still want to report that and do something about it immediately. Call the doctor or the NP or whoever you need to, if it requires treatment, or if it's painful or anything like that, obviously you're going to do something about it. Or God forbid, if it looks, like a strangulated hernia and they're complaining of a lot of pain, you would know right away it would be excruciating. Foley's are real simple. It's always the size, so 16 French, and it says it right on the little port where you would either pull out fluid or where you insert the fluid to blow up the balloon. There's a little kind of port right there where it hooks to the bag tubing, and it'll say 16 FR, 18 FR, 14 FR. That's the size. So 16 French, Foley catheter, patent, and draining clear yellow urine to bedside bag. And you can add the amount in if it's, worth talking about. If it's full, I may not add that in because you're indicating no one's doing their job and emptying that bag and making sure it doesn't, fall off the bed and put pressure and pull on that insertion site. So if it's, a couple hundred milliliters, I might say that 200 milliliters, in the bag, kind of let the reader know. You can't say adequate amount. That's one of my favorites. What the adequate amount, like, yeah, that's good. No, you either have to say how much it is or, empty it before you chart it. And then you'll know that, in your note previously how much was in there, but it's always color and clarity. You could say cloudy amber urine, cloudy concentrated urine with sediment or particles in it. Be specific because that tells you what's going on the inside. What comes out of you is so important to assess correctly because that tells you what's going on the inside. And no joke, I tell my students this all the time. Not only did Scrubs make a fantastic musical about, it's all about the poop, because what comes out of you tells you what's going on. My husband and I were married probably, like, I don't know, 5 or 6 years, maybe not quite that long, before I let him clean my stalls. Because if he didn't tell me what came out of that horse, I don't know what's going on the inside. Now he's like, hey, mercury was a little loose yesterday. So he knows it matters because that tells you what's going on the inside, or God forbid if there were worms or if there wasn't enough, there was only 2 piles in a, 24-hour period. That's not okay. So what's going on the inside is indicative of what you see on the outside. So it's super important that you describe that urine. And you don't have to talk about the insertion site. The insertion site only matters when you created the site. So when there was already a meatus, we don't talk about that site. I mean, you can, but it's a meatus. It should be a hole that you put something into. So that's pretty normal. Just like an NG tube, we don't necessarily discuss the nair. We might say, the size of the NG tube to left nair, to low intermittent suction, and you may describe the drainage, depending on what's in there. It's almost always, bile color. So there's not, too much to discuss there, but you're not necessarily going to say what the nair looks like because that's a hole and it's supposed to be there. It's going to be there before you. It's going to be there after you remove that NG tube. Same thing with your meatus. Now, when we talk about stomas, that's when you want to discuss what that stoma looks like. So whether it's an ileostomy, a colostomy, or a urostomy, you always describe the shape, the size, and they should all be round. Let's hope, they may be oval, that sort of thing. And you want to add that in there if it's abnormal, but they all should, they start out round. They should basically stay round. But the size, so always measure, and it's always diameter. So 6 centimeter ostomy, and you want to talk about it being pink and moist, because remember, that's kind of the inside folded out around the outside and kind of creating this little, structure to keep what's on the inside continuous to the outside, to where they kind of create that, fluff over, like kind of like your cuff, they kind of pull the inside out and kind of cuff it out. So that's sort of your ostomy, right? So the inside is now the outside, and it should look the same. Not the surrounding skin. That surrounding skin should be intact, and you're going to talk about that. But that stoma should be pink and moist, ideally, no matter what kind of stoma it is. Your trach stomas aren't so much pulled out like that way. That's kind of a hole that's created, and it's not a trach hole. Although that did make my day. You know who you are. Love you, girl. But it's not a trach hole. Makes me want to put my pinky in it. It is a stoma. So the tracheal stoma, if you ever have to describe that, which you may in cleaning it, but for the most part, when you're assessing it, there should be a little, trach sponge around it. You shouldn't necessarily have to look directly at the stoma. Now, when doing trach care, you may describe that a little bit, but on average, when we talk about the trachs, it's the size of the trach, the millimeter of the trach that's in there, and then if it's hooked to anything. So if you chart it to where nobody would say, well, where was it located? Was it midline? Was it off to the side? Was it, cattywampus? Not that you would ever chart that, but you need to describe it to where there's no questions. If you hand it to somebody else and say, do you have any questions about this? Or, am I leaving anything out? And they can't possibly say, well, size, shape, color, location, what was coming out of it, what was going in of it, what size was the apparatus coming in and out of it. Then you've covered all your bases. So again, I'm not going to tell you exactly how to chart each thing. I don't need to. Use your head. You came this far. You're smart enough to do it. Just be specific. Don't write a book, but be specific. Don't leave anything out. And sometimes you may put too much in there and your instructor will fix it, or, your supervisor or your preceptor, whatever, may say like, oh, you don't have to do that. Like we don't have to count teeth. Although I loved it. We don't have to count teeth. So be as specific as you can without writing a book. So when we talk about that stoma, it's the diameter of cross, and then the surrounding tissue, the apparatus hooked up, and then the bag, and then the drainage. So if it is formed stool, we know it's a colostomy. If it is liquid stool, it's probably an ileostomy. And if it's urine, it's a urostomy. So be specific on what's coming out. Not so much amount in that case, because it's continuous for the most part, as long as this patient is eating or consuming some nutrition, they're going to have, some output. So it's not so much about the amount with the ostomy, but the size, shape, color even, I would say brown or green liquid drainage or green liquid stool. When we talk about a fistula or, a shunt or fistula in the arm that was created for dialysis, you of course are going to talk about the location. And then that you feel the thrill and you can hear the bruit, right? You want to be able to hear the, and that's that sound it makes as the heart beats. It's kind of tachycardic, huh? That's the sound that is kind of forcing from that artery through that kind of created little bow tie into the vein, and you're going to hear it kind of swirl in there. And then you're going to feel it also, just like you would feel your pulse. That is the pulsing from your heart going to that fistula. So you need to feel the thrill and to hear the bruit. And then you're going to chart that just as such, the location, and that you can feel and hear those two things. And then that's about all there is to it. And yes, you should still have a pulse on that side. Every once in a while, I have a student that, acts like there's not a radial pulse. If you don't have pulses, you don't have limbs. So find the pulse. If you want to chart radial pulses, if that's what your instructor's into, then chart your radial pulse. Otherwise, it's not necessarily related to a fistula. Rectal tubes, again, that's a hole that's supposed to be there. It's going to be there after you leave, after we remove that tube. So in that case, you're just talking about it being in place, and that what that drainage looks like as well. And that's, if they're awake, alert, oriented, if they have any complaints or anything like that, the surrounding tissue, make sure it's not leaking and creating a problem. Make sure before you remove any of these things, you know how to safely remove them. A lot of them have balloons. Your endotracheal tubes have a balloon. Not that you're going to remove those, but don't be ripping that thing out. That has to be deflated first, just like your Foley and your rectal tube. And make sure you know which little port goes to what. And chest tubes, same thing there. Its location, what the surrounding tissue looks like. Chances are it'll be a very occlusive, sealed dressing. That's the whole point, is that you don't want that positive pressure coming into your pleural cavity. You need to create that negative pressure. So whether it's to gravity or to suction, be specific on what you find there. And I'll even say if it's a Stryker or, another brand, say so, make sure you chart that. You want to be as consistent as possible and as complete as possible. So if ever that comes back, you end up in court or, even just the subpoena to, discuss these, or it's questioned, you want to be able to look through your notes and be as specific as possible, and have those details there to where maybe you can even jog your memory if need be. We talked about IVs. That's always, location, anterior, posterior, lateral, medial, be specific. And then the insertion site and the dressing, right? Insertion site is without redness and edema, and the dressing is clean, dry, and intact. And then if anything is flowing into it, you always want, if it's a medication, you want milligrams, micrograms, or units. It's not milliliters. Your fluids are milliliters, LR, salines, those types of things. Anything else that is different, if they have glasses on while you're doing your assessment, then I would say glasses intact. You always say like patient wears glasses. Well, anybody can wear glasses. Are they on right now? Or, full set of dentures in place or on the bedside in a cup. So be specific as you're going down that patient, head to toe. Make sure you have everything in there that you need. like I said, we don't chart scars, but if there's anything specific or anything opening up, when we talk about dressings, you describe that wound. So in your assessment, you're either describing the open wound that is not dressed or the dressing, not both. In your dressing note, then you're going to talk about both. And maybe we'll do that next week. I'll talk about how to do a dressing change note and exactly what it should say. So if they have, let's say, an open wound, in which case you're going to describe the wound bed, the surrounding tissue, and any drainage, just like that. And don't say, oh, what'd she write? It's literally how you would describe it. The center of the wound is the biggest and most concerning portion. So be specific on how to describe that. The surrounding tissue lets you know if we're infected, if we're making this better or worse, or if it is contained and getting better. For the most part, without seeing it the day before or the day after. You may not know, but for the most part, it kind of lets you know if it's angry. And then the drainage, what's coming out of it. Active blood, don't be scared, that's good. Active bleeding means perfusion, and nothing's going to heal a wound without perfusion. So, we don't want them hemorrhaging, but active blood is not scary. Thick green pus and slime coming out of that, that's a problem. So be specific on any drainage that you've got. And then next week, we'll talk about how to chart those notes on dressing changes, or maybe we'll even talk about trach care, anything else that, if you want to put something in the comments and you got a question or you had a patient that had this and you didn't know how to chart it, I'll, help you the best I can. But don't be so worried about, like, how did she say it, or how does she like it? Or, I always wrote up these notes kind of like examples, and then you guys would copy them word for word. I'm like, that was a made up wound, that was a made up Foley. You have to write it to specific on what you found with your patient. So make sure that you write down with your patient exactly how you found it. And don't be so worried about, like, what'd she say or how'd she say? And you always want to write down, like if I tell you how to do a dressing change, it's really just those 5 simple steps, and you do them. And it's literally what we did. And then when we come out, I say, don't forget to, chart that. Any skill that you did, you have to chart afterwards and make sure you record that skill and how you did it. And you're always like, what you say, it's literally how you did it. I promise. Don't overthink it. Don't make it harder than it is. And I'm going to be saying that again when we talk about NANDAs and care plans. It's not that difficult. I know sometimes the way it's taught makes it a little bit more difficult than it really is, but I assure you it is not that tricky. Just think about what you did, stay chronological time, chronological order. Like I said, that's kind of why we have someone just taking notes during a code. So he's trying to save him, she's trying to save him, she's running to get things, he's running to get this. And there's one person not helping at all, writing it all down. So it can be specific on how it happened as it was happening. And when it's, a code, you need someone to concentrate on just that. When it's this dressing, you took the old dressing off, you cleaned it up, you measured it, you saw what it looked like, and then you put a new dressing on. That's it, write it down. It's that simple, I promise. Chest tube, Foley's, rectal tubes, ostomy, shunts, fistula, wound vacs. Yes, and wound vacs also. And I may even do a video on those also. I see more of those done incorrectly than I see correctly. When we go to take them off, I go into the patient's room with all these students, and as I'm taking it off, I'm realizing it was not put on correctly at all. And if you don't put these on correctly, you can cause this patient to have another surgery. That happened, I think, 2 or 3 times. I took the wound vac off, and the way they smashed the tissue up against the bone, this patient had to have another IND. Think about when you turn that vac on. If you haven't seen it, it's like this big puffy foam, literally piece of foam sponge that we put on. And then when you turn it on, it goes, and it literally just flattens back down. And then why I never have my hair down is then I can listen and make sure there's nothing leaking. So when I know there's nothing leaking, I know we're going to get a good seal. And what's that going to do? That's going to just create constant pressure because we're sucking that fluid out of the depths of that wound, right? Remember how we talked about before in the past, we have to heal things by secondary intention, right? So if you allow it to kind of heal up like this, you're going to create a pocket where fluid and crap could stay and end up causing a bigger issue, infection, tunneling, and all kinds of stuff, right? So we put that sponge in there, not tuck it all the way in the bottom with our foot and cram it in there with a Contip applicator, but just a little to where it could wick out the fluid that's being trapped in that crevice, right? And then you slowly allow it to heal by sucking that fluid out by secondary intention. So we used to do that with packing, and we still do. But if you put that packing in there and jam it all the way in there and you create a hole, you're going to have a hole for life. And I've seen it. I've seen a back wound this gentleman sat up for us to do his assessment, and there was like this crater in his back, and I could tell, with scar tissue and stuff, that not that it couldn't have also been an eaten away wound with bad tissue and that sort of thing, but you can create a hole that literally ends up being a hole for life if you don't allow that tissue to grow in and fill it. So if you keep jamming things in there, it's going to stay a hole for life, right? So you should be measuring, but y'all don't know this, measuring that packing each time, and charting it, and putting less packing in and less packing in and less packing in, to where the whole point of that packing is not to jam into the wound and keep it open. Nasal packing does that. Wound packing, that's not what it's supposed to do. You want to create this hole and keep it nice and open so you can breathe. Won't be long, but you don't want to do that with a wound. You want those tissues to eventually touch. So if you got it all crammed down with packing down here in the middle, it's never going to touch. Less packing, less packing, less packing, or wound vac. Suck out the fluid and allow those tissues to touch. If it's filled with fluid, how are those tissues going to touch? You suck out the fluid, suck out the fluid, suck out the fluid, and now we have closure, right? But when you put that sponge on and it sucks down, if you leave that tissue up against the bone and then put pressure on it with the wound vac, you're impeding that circulation. You're just putting your thumb on all those capillaries and not allowing them to get to the tissue. So you need to make sure that that sponge isn't touching anything but tissue that needs to be sucked out, right? So keep that sponge in the center of that tissue, should not be touching any good surrounding tissue. And then you completely seal that. I kind of cut a little hole in the top, right? Miranda taught me that. You cut a little hole in the top, and then you put your little meat cleaver on top, or even like the little mushroom sponge on top, and then the little meat tenderizer sealant on top of that. And then when you go to turn it on, it will be all puffed up like this, and it'll go and it'll suck right down. And then that's when you get real close and make sure you don't have any holes. And if you do, you have to seal those up. So that's secondary intention. And if you don't do those correctly, then you're going to end up causing that patient additional problems. And I've taken them off and seen that. Then you have to go notify the doctor. And, does that nurse get taught how to do it correctly? Is she reprimanded for causing this patient additional surgeries or anything like that? Or is it like, oopsies, and, nothing happens? Don't do anything you're not comfortable doing. And I've had to do that. I was, called in to do something, and I'm like, yeah, I've never seen that before. Even home health, this specific nurse, this LPN, had to go teach this RN how to do the wound vacs. I'd never heard of them before. I'd never seen them before. I just moved here. It was 15 years ago. And I was doing home health, and this patient had wound vac, and she's like, I'll go with you. And she learned from the rep from the company, and she learned the right way and taught me. And I was like, okay, makes good sense. I understand it. And then the more I took wrong ones off, the more I learned how to do them correctly. And I haven't done them in years. I'm no expert in them, but when you think about just simple physics and you put it together and you think, okay, as soon as I turn that wound vac on, what's going to happen? And you see it kind of flatten down and go over good tissue, then you have to take that all off and trim it down even more so. So when I go to put it on, I'll kind of smash it down. And if it smashes down, flattening out, and touches good tissue, I know that it's too big. So anyway, okay, I rattled on long enough with all those things. I guess my pet peeve for today is she and I. Sometimes it's me. It's real simple. It's not that difficult. Just take the other one away. If you're going to say she and I are going to the store, you're not going to say she and me, right? Because you wouldn't say me is going to the store. You'd say I am going to the store. Or if I said like, yeah, he really likes her and me. It's not she and I, because you would say he really likes her, or you would say he really likes me. It's not he really likes her and I. I hear that wrong so often. It messes with my brain. We're talking like on TV, news broadcasters, intelligent, educated people that don't understand when it's I and when it's me. If you don't know when it's me or I, take the other person away, because sometimes it's me. Now, I do have a bumper sticker on my car that says, it's not me, it's you. But those are to the truckers who keep speeding up and slowing down and speeding up and slowing down while I'm on cruise control. That's why it's not me, it's you. Okay, well, hugs and kisses, y'all. Love you. If you got questions, comments, anything like that, let me know. And then next week we'll do some specific charting before we get into NANDAs and care plans. All right, I'll miss you meanwhile.